I'm Gerard Evan. I'm a Professor of Biochemistry at the University of Cambridge, and I'm funded by the Cancer Research UK.
I'm Charlie Swanton, I'm Professor of Cancer Medicine at University College London Hospital and a Group Leader at Cancer Research UK, London Research Institute.
So you led a debate yesterday which was discussing, should the main research priority to be continuing to develop drugs that are targeted specifically at some of the faulty genes that drive cancer. Gerard, what was your idea behind having this debate?
Well, I think there are many discussions that need to be had at the moment. We know so much about cancer, but there's still so much to discover. There's a limited amount of money available for funding research into it. And it's really a question of addressing, not should we not be doing certain things and only doing other things, but really where the priorities are. If we want to do the best we can for cancer patients in the near future as well as the long-term future, should we be focusing our energies in one place or another? And this debate was designed to get out the idea that we need to have a discussion about whether we should be focusing it on targeted cancer therapies, which have changed the face of cancer treatment over the last 10 years, but we don't quite know where they're going to go in the future.
So you led one side of the debate, which was
I was for, yes.
And Charlie, you were most strongly against it.
Yes.
What was the summary of your argument?
Well, the summary of the argument is that in the clinical setting, the targeted therapies came into clinical practice with a much hype and hope. And I guess rather sceptically what James Larkin and I would say, on reflection, they perhaps haven't delivered up to their promise in terms of achieving what we hoped 10 years ago would be cures in the metastatic setting. We're really not seeing that. We're seeing prolongation of what's called progression-free survival, but very few examples where we actually see that these agents truly increase overall survival. And the argument that we put forward was one where we're not saying for a minute we should stop science or research into the targeted therapy arena, into the development of therapies targeting oncogenic pathways, but we also think that there should be a balance, and that balance should be struck about trying to develop new approaches that begin to tackle some of the sort of fundamental problems we see in tumours, namely their underlying diversity that spawns resistance to treatment. And there are many ways we're thinking that this could be done, or that perhaps this already is being done through perhaps the use of optimal immunotherapy approaches, or a better understanding of what's driving tumour diversity and ultimately driving resistance to these targeted agents that we're using.
So you're very in favour of these kind of specific molecular targeted agents, Gerard. Where are you coming from with this?
Well, I think, we all have to understand that we live in the real world and ideas go in and out of vogue. And so I think what I'm anxious about is that targeted therapy is a very young technology. We're not targeting many things at the moment. We know that there are engines that would make much better targets than many of the things we're able to attack at the moment in terms of the drugs that we can make. And I'm anxious that we don't throw the baby out with the bathwater. If people get the idea that the latest thing is immunotherapy, then everyone's going to jump on that bandwagon. I think Charlie's hit the nail on the head. We need a balanced approach. We need to understand that some technologies are embryonic still and have a long way to go. And I would agree with him, we're not curing many patients with targeted therapies. On the other hand, we do understand much more about the molecular architecture of cancers and what keeps them going. And I think it's only sensible to think about ways of designing drugs that hit those particular nodes that keep the cancers going. But I would absolutely agree. The debate was not intended to be partisan. It was intended to bring out the issues and to get the audience involved. And I think it was actually very successful. And Don Ogilvie, who spoke with me in favour of targeted therapies, I know he agrees with me on all of those points.
One of the interesting things was that Don went through some of the success stories of targeted therapy, and we see great success with Gleevec for treating certain types of leukemia. Many people feel that the future is in combinations of these very targeted agents, and Charlie, you're concerned about putting all our hope in combinations.
Yeah. I'm much more sceptical about that approach, and the rationale for combination approaches is essentially that tumours don't have one driver, they have many drivers, and we have to target multiple drivers at the same time to maximise tumour response. The difficulty is that no individual tumour is going to be the same as any other tumour, so each patient would require their own specific personalised drug cocktail, if you like, to maximise tumour kill against all the potential, what we call subclonal drivers that are present and operating in that tumour. That is, drivers of tumour biology that are present in some cells but not others, or some sites of disease and not others. And I think practically that's a very, very difficult problem. It's going to require drug companies working together. It's going to require drug development programs across a myriad of different potential driver events. It's going to require a bias away from what is the current practice, which is developing Me Too drugs, where you have 6 or 7 companies developing programs against one drug target, which we see time and time again, that waste trial resource. So I just practically can't see that really developing very far in my lifetime. The other aspect of this is that we're not talking about targeting. A lot of the sort of theories behind combinatorial approaches in the clinical setting derive from our experience treating bacterial infections, for example, where we're used to treating with 2 or 3 antibiotics or 2 or 3 antiretroviral agents at a time to treat HIV, for example. And the rationale behind that is that retroviruses, bacteria and humans diverged in evolution billions of years ago, and therefore we can successfully target proteins that are operating in a bacteria that don't have homologs in human cells. The therapeutic window, on the other hand, in cancer biology is much, much narrower. We're talking about targeting subtle alterations in gene dosage or subtle alterations in gene function that have on-target effects on the same proteins that are operating in normal human cells. And because of that, the challenge of combining these targeted therapies is much, much, much greater than it is with treating a complex bacterial infection or a retrovirus.
And Gerard, though, your work is trying to target some of the really key, the gatekeepers in all this cloud of targets. Do you think that really going for the most important things is going to be the way forward? Yes,
I mean, I absolutely agree with Charlie. We both are convinced of the value of looking at cancers as evolving systems, and evolutionary diseases, if you like, of somatic cells. But I think there's he obviously espouses this notion there are many drivers, and I think there are, and if you knock out one driver, then another one may evolve and activate, and then you have to chase that disease down. And every one of these drugs, but every time you whack, you don't just hit that driver, you hit that driver and that molecule in normal cells, and then you also have some off-target effects, and your side effect profiles basically spread out exponentially. But I think there's a different issue. Hitting the drivers is not what I'm advocating. I'm advocating hitting the engines. Now, there are conserved engines that I think cancers cannot do without. There are lots and lots of drivers, for example, of the RAS signaling pathway. Lots of receptor tyrosine kinases, and any one of them can do the same job to activate RAS, but there's only one RAS node there. RAS is the engine, MYC is the engine, E2F is the engine. I think we need to hit the engines and not worry too much about the drivers.
But these are very hard proteins to target with drugs.
That's
where are we going to get some new drugs in these areas?
Because we need people who are courageous. I always say courage is the most underestimated virtue of good science. We need people who are courageous, and I think this is exactly the sort of thing we can do in the UK, where the cancer funding is from independent charities who don't have to follow trends. We can make brave decisions here, and I think we need to try and make drugs against these engines. Now, I don't know what the side effect profiles are going to be. I don't know how useful they're going to be. We don't know. But it is a challenge, but I think it's a challenge worth fighting for.
So to sum up, Charlie, your kind of key challenge going forward.
So I mean, I think one thing we haven't discussed here is actually Gerard and I agree on this issue in general. So I think the problem with the debate is quite polarised, but in reality I completely agree with what Gerard's just said. I think another thing Gerard mentioned that we haven't discussed today is this issue of tumours being forced down routes, that they must go down there. They're sort of it's almost as if we're seeing tumours as sort of pre-programmed to go down routes, and it's understanding that biology up front that may tell us something more about routes through which that tumour will have to evolve through subsequently, as Gerard says. And I think understanding those routes through which tumours must progress through in the future will help us develop better targeted approaches to stop that from happening. I think that's where the excitement's going to be for us.
I agree with Charlie.
I loved in your talk that you gave, you were talking about almost understanding it like a chess grandmaster, to try and stay one step ahead.
That's right, yeah. So, I mean, it is, essentially, this is like the most phenomenal game of chess mankind's ever played against a grandmaster that currently doesn't exist, and we're having to predict, a move 10 moves ahead. And understanding what that move might be could help us make a defensive move up front that stops the grandmaster from being able to make that attacking move that leads us to fail.
And Gerard, the debate that we had, it was absolutely fantastic, and lots of people had lots to say. How would you sum it up?
I would sum it up as the fact that we are, as always, on the edge of the unknown. There are strong opinions and passions, which I think is great. That's what drives creativity in science. But there is also healthy objectivity and the ability of people to not be partisan and to be interested in each other's work. Cancer research is a very broad church, and I think that's one of the most wonderful components of it.